Hello guys, let me know in the chat box. Am I clearly audible and visible to you? I'm waiting for your responses on the chat box. I'm waiting on chat box. This is the part 2 of ophthalmology, as we had done the ophthalmology part 1. So rest of the topics we are going to cover today in part 2. I'm waiting for your response guys on the chat box. Am I clearly audible and visible? Everything is perfect. So we can start. Good evening doctors, good evening. Okay. Let me know in the final. Everything is fine, right? Let's start the today's class. And this is the session 2 of ophthalmology. And today we are going to start with the lenses, right? So yesterday we completed the anatomy, we completed the your diseases of cornea, we completed the diseases of conjunctiva, and now we are going to start with the part 2 with the your yes, with the lens. We are starting with the lens. And before starting about the lens, just basic structure of the lens should be needed, right? I hope you know about the lens, but just I'm revising it because if you don't understand the structural or the anatomy of your lens or structure of the lens, if you didn't understand that, you cannot understand the topic, which is the cataract, right? For understanding this, for the understanding that your cataract types, you should know the structures of the lens. Now we're starting with the structure of the lens. The first of all, which is the outermost part of the lens, which is covering the whole lens, that is covered by your lens capsule. Okay, so this is your lens which is covered with your lens capsule. So just I'm showing you uh, by the drawing a diagram like how there is a your lens is covered with the capsule. So the outer part of this lens, right? So this outer part of this lens is the your capsule. Okay, so this is the capsule, or we can say the lens capsule, right? Yes. So this is your capsule which is covering your lens from the outside, from the outside. Now as this is the capsule, now the second thing which we have to talk about it, which is your anterior epithelium. Guys, epithelium, you know, the outermost layer. So we have the anteriorly, we have the epithelium over here. So this is the anterior part, and we have in the anterior part, we have the anterior epithelium. Okay, so what is this in the anterior side? This is the we have the anterior epithelium. Okay, guys, now you are asking, sir, if the epithelium is on the anterior side, what about the posteriorly? Please mention here posteriorly no epithelium. Okay, so please remember about it. The posteriorly we don't have epithelium. Okay, so posteriorly we don't have the epithelium. Only the we have the epithelium in the lens on the anterior side. On the anterior side. Now as we completed with this, now we are moving forward and going inside. Now we have the lens fibers. What we have, guys, we have the lens fibers, and in the lens fiber, please remember about it. The first part which we have in the middle, it is known as the nucleus. Okay, we have the lens nucleus, or we can say the nucleus. the rest of the periphery, right? This the rest of this, we can say this rest of the periphery, this yellow one, right? This is the your cortex. This is the your cortex. Okay. Now, so we have inside the lens, we have the lens nucleus and the cortex. But the last thing which we have here, it's a little bit not visible, right? No one replied in the chat, right? I think now it's clearly visible, right? Okay, now the last thing which we have, the suspensory ligament, or it is also known as jonules of Zinn. So these are the holding this lens, as you can see here. These are the which is connected to the ciliary body. Okay, so this jonules, we can say the jonules, or we can say the suspensory ligament. So these are the jonules. Okay, and it's connected with the your, it will be going to connect with the your ciliary body, guys. Please remember, it connected with the your ciliary body. Okay, it connected with the your ciliary body. Now the ciliary body is going to hold this, right? The ciliary body will be going to hold this lens into the situation. Okay, as it is situated, so it is situated by the, or hold by the your, this is hold by the your ciliary body, and the ciliary body is connected with the lens on the capsule, right? On the capsule we have the, on the capsules we have the our jonules of Zinn, right? The jonules of Zinn, also known as suspensory ligament. Now, as why I'm talking about this all the things, because when we are talking about the surgery of the cataract, right, we have to talk about these structures. Okay, we have to talk about these structures. So that's why this is a very, very important thing which you have to understand. Now, moving forward for the next, which is the diseases part, and this is known as your cataract, right? This is known as your cataract. Very important topic. Every time in the your FMGE exam, they are asking the question from this topic. One question surely from this topic, from the cataract, right? And what is the definition of this cataract? The definition of this cataract, this is the cataract is the clouding or opacification of the transparent crystalline lens. The normally we have the transparent crystalline lens, right? But now it will be not remain the transparent, it will be your clouding of the lens, and it will be going to leading the blurred or impaired vision. Please remember, it will be going to make the your blurred or the impaired vision. Now, talking about the next, what are the risk factors are available there for the cataract? Please remember, there should be the age, as we already saying here, more than 45 year of the age. Okay, the age should be here more than 45 years, right? So this is the mandatory, right? If it is less than 45, then we are saying is the juvenile, right? Juvenile cataract, that is different, that's different, right? Now, of course, there will be the family history will be present, and with the family history, there are the more risk factors like diabetes. If the patient is diabetic, they can get more earlier or easily. Smoking, excessive alcohol consumption, and prolonged exposure to sunlight, eye injuries and inflammations. Certain drugs are there which is lead to the your causing your cataract, like the steroid we can say, which is the toxic cataract we are saying. Steroid is there, rifampicin is there, right? Ethambutol is there, and many more drugs are there, and poor nutrition, and previously done the eye surgeries. Maybe previously the patient had some eye surgeries, so that can cause the, that can cause in the patient, that can make the risk factors for it. Okay, now after the risk factors, guys, now we are starting with the your cataract type, starting with the first one, which is the your senile cataract, right? By the name only you are understanding senile, it means the old age. So the old age patient is getting the your cataract, and you can see over here, as I already told you, the all are the refractive mediums. I hope you remember about the all the refractive medium. I'm revising it. First is the cornea, second is the your aqueous humor, third is the your lens, and the fourth is your vitreous, right? Now, if out of this refractive medium, I already told you they all should be transparent. Now, if the transparency is lens transparency is the lack of it, so there will be the vision difficulty in the vision, or the blurring vision, vision blurring will be the blurry vision will be going to see, right? As we talked about it. So this is, you can see over here, this is, you can see that what we can see, there is a clouding of the lens is seen, right? There is a clouding of the lens is here, right? Can you please share the PDF? Of course, doctor, we're going to share this PDF on the Meduhub channel, Telegram channel, right? So just wait there. Yesterday PDF also, and this PDF will be also will be available over there, right? Meduhub Telegram channel. I hope this is given in the below link, right? There is in the video. You can find over there the link of your Meduhub Telegram, right? Or just search on the Telegram Meduhub, right? Okay, doctor. Now, moving forward for the next, that in the senile cataract also we have the types. The first is the immature type of this cataract. What is the meaning of immature? In the immature, this is will be remain the grayish white lens with the clear cortex, and we can say also maybe there is a swelling will be there. We are saying this to the intuminant cataract, and now it is not mature. Like we can say this, the immature cataract is there, just started. Okay. Then next we have the mature cataract. What will be going to happen? The entire lens will be the pearly white. Your entire lens will be going to get the pearly white. As it is a pearly white, now there is a blurring. Your vision will be started. Right? In the immature cataract, the patient is having the difficulty in the vision. But now there is a vision will be going to affected fully. And the next, which will be the third one, which is the your hyper mature. Now, what happened with the mature is okay. Now in the hyper mature, what will be happen? There is a lens will be the lens cortex, as we talked about the cortex, that will be going to liquefy. Liquefied means that will be going to convert into the liquid and leaving a fluid filled lens with the brownish nucleus, right? So we'll talk about it, about the hyper mature cataract. And please remember, in the hyper mature cataract is also sometimes the sclerotic type. What is the meaning of sclerotic? There will be the shrunken lens with the wrinkle and the thickened your anterior capsule, and that's why there is a scene the deep anterior chamber and maybe can cause the iridogenesis. And between this, I'm going to show you about the all the type of cataracts you can see in the immature senile cortical cataract. You can see over there that is starting of, you can see in the lens there is a starting of the clouding. The clouding is started, okay, and slowly it is getting the whitish clouding over there, right? Whitish clouding will be there. There is a getting the whitish clouding. Now it is getting the whitish clouding. Also it is immature still, right? It is a immature, but when it is will be going to convert it into the fully mature, this will be going to convert it into the pearl white. Totally, you can see over there the total entire lens is now the pearly white color. And the last one which you are talking about it from the hyper mature, you can see over here, this one is your liquefied cortex, and this one brown color one, the your nucleus, or we can say the sunken nucleus, right? It is coming downwards because as it is the now we can say the fluid filled lens is rest over there, right? So this is known as the your hyper mature. Also, this is having a special name which is known as Morganian hyper mature senile cataract, which is known as your Morganian hyper mature senile cataract. Right now, in the immature cataracts, just we are starting with the now, as we talked about the immature, mature, and hyper mature. Starting with the immature cataract, there is the first one which is the your nuclear senile cataract. In the immature, we have the nuclear senile cataract. What do you mean by the nuclear cataract, guys? Just simple. As we talked about it, as we talked about your anatomy of the lens, we talked about the anatomy of the lens. In the anatomy of the lens, I told you that there is a nucleus is there, right? So if the only the nucleus is started, so what will be happen now? The clouding is starting from where? From the nucleus. It will be clouding will be going to start it, and it will be going to spread to the periphery. from the central to periphery like this. Okay, I'm drawing in the image, just check it out. So it is starting from the central part because the nucleus is in the center. All right, so this is starting the clouding from the central part. And what kind of appearance it will be going to give? It will be going to appearance will be the hard and inelastic lens with the central to peripheral opacification. As I already told you, it is starting from the your opacification will be going to start from the your central part. Okay, from the centrally it will be starting, and it will be go to the periphery. It will be go to the periphery like this. Okay, and what will be the clinical feature will be going to seen over here? What will be the clinical features will be going to seen in this? The first one, there is a glare will be going to seen by the patient. What will be going to seen? There will be the glare will be seen. And what is the mean of glare? There is a, due to this glare, the patient will be the bright light intolerance. So the patient is having what? The patient is having the bright light intolerance. The patient will cannot go to the bright light. Okay. The next, uniocular polypia. What do you mean by the uniocular? Please, the diplopia is there with the double vision. Okay, I'm not talking about the diplopia. I'm talking about the uniocular polypia. This is the double or the multiple images by the one eye only. Okay, so uniocular. We talked about the uniocular polypia. It means from the one eye only, which eye is affected, which is having this nuclear snile cataract. It will be giving you what? It will be going to give you the multiple images. Okay, what it will be give you? It will be going to give you the multiple images. Okay, now sorry for this, right? Okay, now it will be going to give you the multiple images. It will be going to give you the multiple images. Okay, now not only this, if we're talking about the next, this is your color halos. What will be going to talking about here? We are talking about the color halos. What is the mean of color halos? This color halos is the light dispersion. What do you mean by the light dispersion? As the light will be going to pass through it, it will be changed into the seven colors, right? Vibgyor, right? So it will be changed into these colors, and the patient is feeling the color halos due to this light dispersions. Also, there is some black spots will be going to seen, which are the stationary spots. The patient is saying that something is the black spot is in front of my eye, and they are situated there. It feels like something is in between my vision, and the patient can say that some flies are like the flies are there, right? Some house flies are there seated on my eye, right? And the ruler patient give you such clinical symptoms, right? And the vision is affected. The totally they want to say that due to this black spots, there is a vision is affected, and they are the stationary. It means they are not going away. They are stable over there only. Also, the blurry vision, as we already talked about it, the blurry vision will be there, and maybe the musty and distorted vision will be going to seen in the patient. And the please remember here, there not only the blurry vision is in the starting only it will be the blurry vision, but later on the gradually this will be going to loss of vision. And please remember, it will the painless distortion. What is the meaning of the loss of vision? Is totally painless. There is no pain will be there. Okay, we are not talking about the pain. The painless vision loss will be seen in this condition. Right, now talking about the your next about the cataract sign. What sign will be going to see? If I'm going to check the visual acuity test, right, which we can say the Snell's chart. I hope you know about the Snell's chart, right? What is the mean of Snell's chart? I hope you visited your ophthalmology clinics, who guys are having specs or maybe for the regular checkup of eye. So you saw there is a chart which is going to read by from the 6 meters. And what is the there is in the starting there is a one letter, then two. By if I'm going from the above to downwards, there are the letter number is increasing, and the letter size is going to decreasing, right? So that is your Snell's chart. And in the visual acuity, if I'm talking about this patient, this visual acuity will be going to range from the your 9/6 from the your projection of light is presented. All right, so this will be the your visual acuity testing. Also, there is the oblique emulsion. Emulsion will be seen, will be the reveal the lens color, right? We'll do the oblique emulsion. So there will be the reveals the lens color, the which type of the lens is giving the coloration. Also, the iris shadow test. Now listen this part. There is the iris shadow test is important test for the identifying this is the immature cataract or the mature cataract is there, right? So if I'm talking about it, so what we are going to do, we turn on the light on the in front of the patient, and if iris is making a crescent shape shadow on the lens, if the iris is making the shadow on the lens, the cataract is immature. But if there is a no shadow is visible, please remember, if there is a no shadow is visible, the patient is having the mature cataract. Okay. So just by this shadow test, iris shadow test, we can identify there is a maturity of the cataract or the mature cataract is there. Also, we can do the diet ophthalmoscopy. Please remember, we can do the diet ophthalmoscopy, or we can say that from the distance ophthalmoscopy, we can say this, right? From the diet ophthalmoscopy, distance of. So if there is a no cataract, please remember there is the reddish yellow glow is coming from the eye, from the distance, okay? And if there is a partial cataract, there is a black shadow will be going to seen over there on the diet ophthalmoscope. And if the complete cataract is there, please remember there is a no glow. The patient is the on the diet ophthalmoscopy, the patient is having the no glow. Okay, there will be the no glow on the your diet ophthalmoscopy. Also, now we have the slit lamp biomicroscopy. So in the slit lamp, please remember we have to do the pupil will be fully dilated. So we have to give the cyclophagic drug for the dilation of the subpupil, and we have to reveal the opacity details. We have to see like from where the opacity is starting, the nuclear cataract or your cortical cataract, type of the cataract, which type of the cataract is there, right? Also, we can see the opacity is which type of, like, is the immature or the mature, or maybe there can be see the hyper mature also. Now, what is the mean of nuclear hardness? If there is a soft, it will be the color of the yellowish color. If there is a intermediated, it will be the dark brown color of your lens will be there. And if it is a hard, it will be giving you the black color here, right? So now you can see over there in the immature cataract, and there is a iris shadow on the mature cataract, if I'm talking about it. So you can see over here as we turn on the light. So what we can see, you can see over here this shadow. Okay, this shadow is known as the iris shadow. What we can say this the we can say this the iris shadow. And on this iris shadow, if this iris shadow is present, what is this? This is the your immature cataract. Immature cataract. Okay, and if there is a no shadow, you can see over here there is a no shadow. Okay, there is a no shadow, and I told you if this is there, there is a mature cataract. Okay, this is the your mature cataract. Also, as we talked about your slit lamp by microscope, which will be going to reveal your hardness of the your cataract. So if it is seen the black, that will be the totally we told about it. This is the totally your hard, right? Or intermediate will be the brownish, but you can see over here this is the bluish. It means it is the soft. Okay, yellowish is the your soft. You can see over here yellow is the soft, and dark brown will be the your intermediate, and the totally black will be going to give you the hard. Now, talking about the cataract complications, what complications we can see in the cataract patient? So please remember about it. The first one, which is the your phacoanaphylactic uveitis. As we talked about it yesterday in the anatomy of the your eye, the intermediate your layer, which is the vascular layer and also known as a uveal, right? We talked about it. It's a uveal tract. So if the inflammation of that middle layer, that is known as your uveitis. That is known as your uveitis. So due to this cataract, there is a uveitis can be seen because of that the lens protein can be leaked into the anterior chamber. And this lens, which is a secret, which is a leak, this protein can causing the uveitis, right? Inflammation of your iris, inflammation of the ciliary body or the choroid also. And the next we have the lens induced glaucoma, which is important, right? We talk about the glaucoma in the later part. So then I'm going to tell you how type, why this is going to cause it. But please remember about it. There is a two type of glaucoma can be caused by the cataract. The first is the phacomorphic glaucoma due to the swelling of your cataract. And please remember that is always by the intusiminant cataract. It means the mature cataract. Okay, that is why they are mature cataract. And if I'm talking about the phacolytic glaucoma, this is from the protein leakage. This is always from your protein leakage, and due to this protein leakage, there will be the protein leakage will be in which condition? The protein leakage will be seen in the your hyper mature. Okay, the protein leakage will be going to see into your hyper mature cataract. And please remember, as this is the phacomorphic, by the scene, the phaco it means the lens, morphic it means the morphology. So there will be the lens will be getting swollen. Okay, your lens will be getting swelling over here. And if I'm talking about this phacolytic, what will be going to happen in this phacolytic? There is the leakage of protein, lens protein. We'll talk about in the glaucoma. I'm going to cover up this two type of the glaucoma also in the complicated glaucoma, right? Just remember about it. Okay, so the lens swelling cause the phacomorphic, and leakage of this protein, which is the lens protein, this cortical protein, will be going to cause your phacolytic. Now, the next is your subluxation, or we can say the dislocation, right? So, if due to the zonule will be getting degenerated in a hyper mature cataract, so this zonules which are holding this your lens on the position, right? If they will be going to getting tear, right? If they will be going to tear, right? If they tear, the lens will be cannot possible to stay over there. It can drop backside into your posterior segment, and that is known as your subluxation or the dislocation of the lens, right? Dislocation of the lens, right? Now, moving forward, we completed the senile cataract. Now we are moving forward for the next type of the cataract, which is the your known as your metabolic cataract, right? Which is known as your metabolic. By the name only you are understanding the metabolic. It means some metabolic diseases also present there, which will be going to cause the cataract. Though starting with the first one, which is your diabetic cataract. So of course, the patient is having what? Diabetes mellitus. The patient is having the disease which is known as diabetes mellitus. We talked about this. The diabetes is a risk factor for the senile type of the cataract. Also, of course, what it can do, the diabetes can do in the senile cataract, it will be going to cause the early onset. The patient is getting the, like if the normal person is there, I'm just comparing this why the early onset is there. If a normal person who is having the non-diabetes, we can say the non-diabetic person and the diabetic person. If a non-diabetic person is getting the cataract at the age of 48, so the diabetic person will be going to getting the at the 45 only. So the early onset will be going to seen in the diabetic patient. Also, there is a rapid progression as it will be going to start it. So this will be going to progress rapidly. Okay, so it is maybe started as a, of course it will be going to start as an immature cataract, but this will be going to convert into the your mature cataract very rapidly. Also, the different type, the second type, if I'm talking about it, the senile type, we talked about it. The second type, which is the famous and also a name and culture is given to it. This is known as your snowflake cataract. What is the name of it? Snowflake cataract. And please remember, this snowflake is the fluid vacuoles which are seen as like snowflake, right? And this is the image which is the previously asked in the exam. So it is a PYQ that previously this image is asked in the exam, right? That what, which type of cataract is it, and due to which metabolic condition it is seen, right? So please remember about it. This is seen in the your diabetic cataract. This is seen in your diabetic cataract, and just they ask this also that this is due to which substance accumulation. So write down here sorbitol. Okay, this is due to which substance accumulation will be here in this snowflake cataract, that is your sorbitol. Now moving forward for the next one, which is your galactosemic cataract. Due to the galactosemia, right? Due to the galactosemia, there is a seen a cataract in the children, right, which is a bilateral. Please remember this will be seen as the bilateral, and also it is also having a special name which is known as the oil droplet opacity. So it seems like that there is a oil drop is here in the on the lens, right? So we have put it a drop of oil on the lenses, so it is known as the oil drop cataract, right? Also known as the oil drop opacities or the oil drop cataract. And please remember about this is a special thing that it is a reversible with a diet modification, right? So this is the only the importance about it, that please make a question mark here, okay, that this is the cataract which is the reversible type. Okay, so what about the others? Yes, if the diabetes or any other cataract, senile cataract, diabetes cataract is there, we have to do surgery. Okay, we have to do the surgery of that patient, right? But what about this? Just by the diet modification, okay, by the just doing the diet modification, we can reverse it. Okay, we can reverse it, right? So it can be, the patient can be back to normal. Okay, next we are starting with the next, which is the your name is a hypocalcemic cataract. And please remember about it, about the hypocalcemic, it means it is always and always associated with your parathyroid tetany, right? So the parathyroid tetany will be happening what, there is a hypocalcemia, right? And in this hypocalcemia, please remember, in this hypocalcemic cataract, this is the multicolored crystals or the white flags will be going to seen, right? This white flags will be going to seen to you. Okay, now not only this, the next type which is the important, that is your copper metabolism cataract, right? The copper metabolism cataract, it means a disease you know very well, which is your Wilson disease, right? Wilson disease. In the Wilson disease, there will be the going to seen to you a special type of cataract because of this copper metabolism, which is known as, the name is the green sunflower cataract, or we can say the sunflower cataract. Okay, so it seems like it is a sunflower is on the lens. You can see over here, this is the sunflower. Okay, and this is your sunflower cataract. This is your sunflower cataract. Not only this, the next we have the Lowen syndrome. And what is this mean of this Lowen syndrome, guys? Please remember, in this syndrome, the patient is having the congenitally two disease of eyes, which is the cataract and the glaucoma. Okay, the both. Please remember about it. Make a star over here. It is having the both, right? The Lowen syndrome is having the two type of eye disease. And what are those two? Those two are the cataract and the glaucoma, right? So maybe they can ask you with this. And please remember, not only this, in the Lowen syndrome, the patient is having the systemic features like a mental retardation. The patient is having the mental retardation, and the congenitally it is having the your cataract and the glaucoma. So this is all about your metabolic type of cataracts. Not only this, some more cataracts are left over there, like the complicated cataract. What do you mean by the complicated cataract? Like causes are there, like uveal inflammation, which is the uveal. We talked about the uveal tract inflammation, which is known as uveitis. Also, there is the retinal detachments, glaucomas, and the intraocular tumors. This can cause the complicated cataract. And please remember about your features of it. The posteriorly cortical cataract with the irregular opacity. It will start from the posterior side, right? We don't have the posterior epithelium, but it start from the posterior cortical cataract, and it is having the polychromatic lusters, right? There will be the same new special thing, which is the polychromatic lusters will be going to see, which is a special feature of this complicated cataract, right? Complicated cataract. Not only this, we have the some toxic cataract. What do you mean by the guys? The toxic cataract, like the corticosteroid induced. If the patient is using the corticosteroid eye drops, or the patient is taking the systemic corticosteroid from the prolonged time, the patient also seen with the posterior subcapsular opacities. Some mitotic induced, the patient is having the mitotic drugs for relieving the pain or maybe for the glaucoma. So it is going to cause your anterior subcapsular granular cataracts. And some other drugs are there, like your amiodarone, chlorpromazine, and golden, etc. Right? Many drugs are there. I hope you studied in the pharmacology, which is having the complication, which is have the complication of the toxicity for the cataracts. Right? Not only this, not only this about the cataract, we have to talk about the diagnostic criteria of the cataract. Now, what is the diagnostic criteria of cataract? How we can make the diagnosis of it? So just to remember about it, for the making the diagnosis of the cataract, we have to go through the comprehensive eye examination, all right, which is including what? Which is including your visual acuity test. First, we have to measure the the person's visual acuity, right? Is the how much is there, or how much is the eye disturbed, right? So we have to see from the various distances. We have to see the visual acuity test. Also, we have to see the on the slit lamp examination. We have to see all the right. So this will be going to allow the doctor to see the all the structures of the eye and the under the magnification also. So we're going to see the magnified vision of the your lens, right? Also, we're going to see the do the retinal examination. Guys, please remember about this. We have to do surely the retinal examination because maybe the patient is having any retinal disease, right? And now he got the cataract. Okay, now he got the cataract. So what we are thinking, that this visual disturbance, what we are seeing here, this visual disturbance is due to what? Due to the cataract. We are thinking about it, but this is not due to the cataract. It is due to the retinal disease. So we have to see the retina, and now your mind is saying, sir, if the lens is totally clouded, as we talk about it in the cataract, right? If lens is totally clouded, right? How are you going to see the posterior segment, which is the your which is the posterior segment, which is the what? Which is the your retina. In the posterior segment, we have the retina, right? So how will be this retina will be going to visible? So please remember about it. Just mention here for the retinal examination. Just after the dilating pupil, doctor examine the retina for the cataract presence by the indirect ophthalmoscope. Okay, so the patient will be going to see the indirect ophthalmoscope. Through the indirect ophthalmoscope, we can see, right? We can see the retina in the hazy medium also. Also, we have to do the tonometry test for the measuring the pressure inside the eye, which is also known as intraocular pressure. We talked about it. Why? Because maybe due to this cataract, now this is going to complicate it with the complicated cataract like the phacomorphic or maybe the phacolytic glaucoma. So we have to do the management of it. Now, talking about the next, which is the cataract management, which is the important question from here, from this how to manage this cataract. Please remember about it. We don't have any medical management of it. We cannot treat the cataract through the medicines, but yes, we can treat the underlying causes of this, which is causing this cataract, like diabetes, or maybe some cataractgenous drugs the patient is having, this steroid and all, or maybe the mitron the patient is taking. Also, we can delay the progression. We can just delay the progression. I'm not saying that we can cure it. Okay, if it is started, so we can delay the progression. Like it will be going to slowly, right, progress. We can give the iodine salts, or we can give the multivitamins, so that can suppress the progression of it. Also, some vision aids we can give to this patient for the like refraction or for the illumination, or the dark goggles can be given, or the mediatic drugs can provide to this patient for the helping this patient with this cataract. Okay, now this is the just for the management. But if I'm going to treatment, please remember about it. In the treatment, we have the surgical treatment. And what is the indication of this surgery? Please remember about it. It is not like that the patient is coming to you and we have to do the surgery at the time only. We have to see the indications. Surely, what are the indications? The patient is having the visual improvement after the surgery. If there's a retinal detachment in the posterior segment and the cataract is also there. Now I know if I do the cataract surgery, there is a nothing will be going to see in the improvement, will be no vision improvement will be going to see. Then why I have to do the surgery? So there will be the surely, I'm damn sure about it before doing this surgery that yes, after the doing surgery, the patient will be going to see the what? Visual improvements. The patient will be going to get the visual improvements. The first thing. Now we have to see the some patient medical condition. We have to see the patient's medical condition, like for the other systemic disease, maybe as a hypertension is there, or maybe the patient is having gone through some different drugs, right? So we have to see this all. Also, some cosmetic reasons, right? We have to see the in the indications of it. But for the doing about it, there is a before the surgery we have to do some pre-operative evaluations. And what are the those? For the general medicine, for the general medical checkup, we have to see any systemic diseases underlying over there. So we have to see first of all that. Then for the ocular examination, we have to examine the retina function, infection sources, or the anterior segment. I have to see the anterior segment clearly. Also, if I'm talking about the intraocular pressure management, if there is a raised intraocular pressure, I have to manage this intraocular pressure. Okay. Now, this is the pre-operative. But what the pre-operative medications should be given? The medications I have to give uh, before the surgery. I have to give the antibiotics, which is the prophylactically antibiotics we are giving here. Also, I have to do the pupillary dilation by the cyclopages, and I have to reduce the intraocular pressure for this patients. Understood? This is the basics I have to do. Now, what about the patient? What about the patient? Anesthesia will be there. Mostly we are doing in the local anesthesia. Please remember, the most common is the local anesthesia. If the patient is not cooperatable, right? The patient is having the fear of operation theater, or maybe the patient is mentally disturbed, and he cannot go on through this surgical procedure, right? So then we have to do the general anesthesia. Otherwise, we can do in the local anesthesia. Like in the local anesthesia, we can do the surgery. Now, not only this, we have to talk about the different type of surgical techniques are there, which questions are going to ask on your exam. The first one, which is known as your intracapsular cataract extraction, right? What is this known as? This is your intracapsular cataract, and this is the, please remember about it. Please remember about it that this is your old method. Okay, this is a very old method. Nowadays, we are mostly we are not using this method, but maybe in some government hospitals are using this methods, or maybe in some eye camps, right? In some eye camps, they are using such a method because it is a low cost and simple also, right? So that's why we cannot do this normally. But if the patient is coming with the complication, like the patient is having the subluxation of the lens, now we don't have any other option to do for this. For such patient, we have to do this. So there is an indication is totally given. If there is a markedly subluxated lens is there, we have to do this. What is the advantage of this particular uh, surgery technique? That is the simplicity. It is very simple and low cost also, very low cost. We can say the uh, just nothing. Okay, just nothing. Okay. Also, and disadvantages are there. What are the disadvantages we are going to get? We cannot implant the posterior chamber intraocular lens. As we normally we are having the lens into the posterior chamber, we cannot put this posterior chamber intraocular lens. And please always and always remember, it is having very high complication. So this is the type of the surgical technique is having a high complications. Okay. Now, not only this, the next we have the extracapsular cataract extraction, which is the ECC. Now, what is this in this condition? This is used nowadays. Okay. What we are doing in this, the indications is there. It is preferred for the most cataracts. In all the cataracts, we can do this extracapsular cataract surgery. And what is the advantage? Please remember, it is suitable for the all the ages patient. We don't have any issues. Also, we can put the posterior chamber intraocular lens, and only fewer complications are over there. Okay, but the disadvantage is also there. What is the disadvantage? If it is a less applicable for the markedly dislocation, if the dislocation of the lens has happened, now we cannot do this. Now we cannot do the ECCE. Now, also we have the next, which is the manual small incision cataract surgery, which is known as SICS. This is also a good surgery. But nowadays we are not doing so much this. We are following the phacoemulsification, which is the fourth one we are going to talk about it. But what is the advantage of this surgery also? This is also the low cost and less machine dependent and quick also. This small incision, manual small incision cataract surgery, SICS is this. And also disadvantage is there. It is having very larger incision. So there is a more post-operative astigmatism can be seen as a complication. But nowadays, which is the best, we are using nowadays more over there and best also, that the advantages are here, just a small incision. What kind of small incision? Less than 3 mm. Less than 3 mm we are doing this. Please remember about it. Just 3 mm. Okay, less than 3 mm. And quick visual rehabilitation. Just the patient should have to take the 1 day rest and patient can back to the work. Also, there is a less astigmatism, or we can say that the no, right? There is a no astigmatism can be seen. What is the disadvantages are there, right? What is the disadvantages are there? The disadvantage is the high cost. The first and most disadvantage is there. This the patient is having the patient should have to bear the high costs of this. Also, this the all work should be machine dependent work. We have to use a microscope over there, right, for this your your this. And also this is a machine dependent because for the phacoemulsification we have to use the phacoemulsified probe or the phacoemulsified machine, right? Also, this is a very complex learning curve, right? This is a complexity. If I'm talking about for learning for the doctors, it's a little bit a complex, or we can say the complicated procedure over there rather than the SICS. SICS is a very easy to do, okay, rather than comparing to the phacoemulsification, compared to the phacoemulsification. Now, what are the prognosis of this cataract? Please remember about it. The prognosis of the cataract surgery is generally very, very, very positive. It means we done the surgery, the patient will be getting the vision after the procedure only. So, with the most people experiencing improved vision after the your procedure. As we done this cataract surgery procedure, the patient will be back with the vision, and complications are rare, but including the infections, bleeding, and the retinal detachments, these are can cause the poor prognosis of these surgeries. Also, the what is the conclusion? We are coming on the conclusion topic that cataract is the common eye condition, right? Particularly in the older adults, and this is the regular eye care. But with the regular eye care, proper management, and the effective treatment like surgery, the vision can be significantly restored. Okay, so it is not like that if the there's a blurring of vision, or maybe the vision loss is due to the cataract, so we cannot restore it. We can easily restore this, right? We can easily restore this vision. Understood? Right? Okay, guys. So I think this is understandable for you. All right. Any doubt is there? You guys can mention me in the chat box. If you guys have any doubt is there, you guys can just mention me in the chat box. No issues. Okay, guys. So you can mention me in the chat box. Perfect. Now, moving forward for the next, we are moving forward for the next that we are talking about your right. Any doubt? I think there's a no more doubts are there, right? So let's move forward. And now we are moving forward for the next disease, which is the glaucoma. Is there any doubts? I'm waiting for your doubts, guys. If anyone has the doubt, please ask me. Let's move forward for the next topic. If no doubt is there, let's move forward for the next topic. Okay, let's start with the glaucoma. Let's start with the glaucoma. And if I'm talking about this glaucoma, the glaucoma, for understanding this glaucoma, just understand this diagram. This diagram is very important for the understanding the glaucoma. There is a type of glaucoma, right? So we have to talk about it. The first of all, What is this diagram is showing? What is this diagram is saying? Just talk about it. So you can see over here in this, there's a clearly mentioned the first symptom is what? The first symptom is your ocular hypertension. It means there is a raised intraocular pressure more than 21 mmHg. As we talked about it, there is a 10 to 21 mmHg, the normal pressure of intraocular pressure, right? So there will be the first of all, there is a ocular hypertension, which is saying that the intraocular pressure will be more than 21 mmHg. Now, the second option, what can be the feature? The next, there should be the typical disc changes should be seen. This is the typically disc changes, right? So what is the disc changes? The optic disc changes should be markedly there. Okay. Also, this is the second feature. The third feature, there is a typically visual field changes should be also available, right? So if this three, all the three are there, that is known as your established glaucoma. That is known as your stabilized glaucoma, right? This is known as your stabilized glaucoma. Okay. Now, if there is not the three, but first symptom, this is the important should be there. If this is present and any other is present, like this and this is present, that is also known as the glaucoma. The ocular hypertension and the visual field defect is present, that is also known as the glaucoma. If two is present, then also it is known as the glaucoma. But please remember, if there is a low tension glaucoma, right? What is the mean of this low tension glaucoma? Please remember about it. If there is a intraocular pressure is the less than 21 mmHg, but the patient is having the what? The patient is having the typically disc changes and patient is having the typically field changes. That is known as your low tension glaucoma. That is known as your low tension glaucoma. So I think it is totally clear to you. There's the three features, the three steps or the three things are totally there over which we have to talk about it. Okay, what are those three? Ocular hypertension, first, typically disc changes, second, and the third is the your typical visual field changes. If all the three are there, establish glaucoma. We understood that there is a glaucoma is 100%. But if there is a two features are only present, but the one should be mentioned over there, which is the hypertension, ocular hypertension, and any other symptom. Maybe it is your disc changes or maybe it is your field changes is there with the ocular hypertension. That is your glaucoma. That is also your glaucoma. But if there is a no ocular hypertension, but there is a disc changes and your typical field changes is present, that is known as your low tension glaucoma. Low tension glaucoma. Now come to this part. We have to talk about this. We have to talk about this importantly that there is the etiological factors, right? What is the etiological factors of this? Just we have to talking about it. In the etiological factor, we have the first of all the primary institutes. There is a what is the mean of primary? The first of all, there should be the raised intraocular pressure should be needed. What will be the needed? The raised intraocular pressure. So the first primary institutes are there. The importantly one is the raised intraocular pressure, which is the mechanical theory, through the mechanical theory. And the pressure independent factors are the vascular insufficiency theory. There's the two theories are there, which is from the primary. But what are the secondary institutes, which is your extra toxicity theory, saying that it has continued the neurological damage for your accessory toxins, right? So from the other toxin, it will be going to continue the neural damage, right? The nerval damage, it will be going to continue or continually doing. But starting with the first one, which is the type of the cataract, the first type of cataract is known as your congenital cataract, or we can say the developmental, sorry, we are talking about the congenital glaucoma, or we can say the developmental glaucoma, also known as ophthalmos. We'll talk about it, why this is known as the ophthalmos. Just remember about it. This is the important that congenital glaucoma is also known as your developmental glaucoma. Developmental glaucoma. Now, moving forward with the glaucoma, the first of all, the congenital glaucoma is what? The when this is due to the congenital glaucoma is due to the developmental angle abnormality. Which angle? We are talking about the angle of anterior chamber. This is we are talking about the angle of anterior chamber. Okay, we are talking about which angle? We are talking about the angle of anterior chamber. Also, if I'm talking about the next, which is the developmental glaucoma, this maybe appears in the years after the years of the birth or within a 3 years. It will be going to appear in the within a 3 years. So that will be known as your developmental. Now, it is the congenital. It means that when the child is having the birth, it is present with the glaucoma. That is known as congenital. Yes, at the by birth only it is having the glaucoma. In the developmental period, right, within a 3 years only, the patient is getting the glaucoma. Now, talking about the first one, which is the primary developmental, or we can say the congenitally glaucoma, and what is the cause of it, which is important. The cause is the developmental anomalies of the anomaly of the angle of anterior chamber, right? Angle of anterior chamber. So now this angle of anterior chamber is closed. And why I'm talking about this angle of anterior chamber, I hope you know about it. When we talked about the aqueous humor in the starting of part 1 only, we talked about the angle of anterior chamber, right? And why we're talking about the angle of anterior chamber? Because from the angle of anterior chamber only, the aqueous humor is getting drained, right? Now, also we talked about the aqueous humor, that this aqueous humor is maintaining the intraocular pressure. Yes, this aqueous humor is only the maintaining the intraocular pressure. So if, please remember, if there is a angle of anterior chamber is closed, if angle of anterior chamber is closed over there, now due to this there will be the increasing in the aqueous humor production or aqueous humor accumulation. And due to this aqueous humor accumulation, please remember about it, due to this aqueous humor accumulation, there will be the increasing in the intraocular pressure. So due to this developmental of the angle of anterior chamber, so there is the blockage of anterior chamber angle, and due to this blockage there is a increasing the accumulation, or we can say the accumulation of, just come to this side, there is a accumulation of aqueous humor. Okay, and due to the accumulation of aqueous humor, there is a leading to the increasing the intraocular pressure. Okay, as we talked about it, the aqueous humor is the maintaining the intraocular pressure. Okay, as it is a maintaining, so if there is accumulation of this there is accumulation of the your aqueous humor is there, so of course it will be going to maintaining the intraocular pressure, right? So it will be going to increase. If the accumulation is there, it will be going to increase your intraocular pressure. Now let's move forward, that the main feature of this, the main feature of it is what? The main feature will be going to see in your elevated, we talked about it. The main feature is what? The main feature is your elevated intraocular pressure. So IOP is your increased. Increase, it means more than 21 mm Hg, right? There should be the there. Also, it is associated issue. No, there is a no link with the any other ocular or systemic abnormalities. It can be only the individual. But what are the clinical features? So there is a triad. Triad means the three symptoms. It is the three clinical features will be initially presented there. The first one, which is the lacrimation. So you can see in the patient, there is a continuously lacrimation will be going to seen in this patient. The second one is the baphlospasm. We talked about this. There is a patient is involuntary. What is happening? Involuntary closing of the involuntary closing of the eyelid, which is the baphlospasm will be going to seen. And the third one, which is the your photophobia. The child is having the fear to see the lights, right? So when we take the child, right, when we take the child into the bright room, or maybe the bright light, or maybe the sunlight, the child is will be going to irritable and start crying, right? But when we take this child to into the dark room, okay, So in the dark room, the child is not crying. Okay, so by this symptom, we are finding this the patient is having what? The child is having the photophobia or not. So this initially signs which you have to see in this photophobia, baphlospasm, and the lacrimation should be this triad should be presented over there. This triad should be presented initially over there. All right. Now, what are the more other? What are the more other? In the more we have to see the corneal sign. We have to see the corneal sign. In the corneal sign, we have to see there is a corneal edema. Right? There is a corneal edema will be going to see, right? So the cornea will be getting adenomatous, and due to this corneal edema, there is a enlargement of this your cornea, and as this cornea will be getting enlarged, now you can see this, right? Can you see this? The blue color eyes, right? This cornea is a totally blue color. Why this is having the blue color? Because it is enlarged. You can see it is enlarged, very big cornea, and also this is having the edema. Okay, it is having the edema and it is having the enlargement over there, right? It is having the edema, and as it is enlarged, so it is looks like as a bull's eye. It is not the seems like the human's eye, it is seems like the bull's eye, and that's why that is known as your buff-thalmos, right? As we talked about it, right? The buff-thalmos. So what is about the buff-thalmos? Yes, that is your bull's eye is known as your buff-thalmos. Okay, so this buff-thalmos means the bull's eye. Okay, this bull's eye is known as your buff-thalmos. Okay. Now, why this is the buff-thalmos? Because of there is an enlargement. Please remember about it. Enlargement of, yes, there will be the surely enlargement of the child's eye, and due to the edema of course there will be the edema is also there. Okay, the both of the things. Okay, the both of the things will be presented over there. Now, moving forward for the next symptom, that there is a descent membrane breakage. What is the mean of a descent membrane breakage? How it is possible, guys? The descent membrane can be break down because as is the cornea is getting enlargement. We talked about in the keratoconus, guys. I hope you remember about it. In the keratoconus also, what was happened? In the keratoconus also we saw, right, that the curvature was increasing, and due to this increasing in curvature, that's why there is a due to the increasing in the curvature, what will be seen? We saw there also there is a descent membrane were getting the tears or the breakage or the stretch marks over there, right? The same thing is happening in here also. Due to this corneal edema, there is a tear or the breakage in the descent membrane of the cornea, and that's why here there were your horizontal, and that's why this is known as your herb stria. This is known as your herb stria. And Voga stria, we talk about the Voga stria, that is a vertical. The Voga stria is having the vertically. And please remember about it, these occurs because of the descent membrane is the less elastic than the corneal stroma, because stroma is very thick and very big, right? So due to this, it is having the elasticity, but there is a descent membrane is the non-elastic, not much so elastic. So that's why this is getting the stretch marks, or we can say the stria marks, or we can say if there is a more stretching of there, so it can maybe breakage or the tear can be seen over there. The tear or breakage will be going to seen over there. And please remember that tear are usually in the peripheral, and this is constricted with the your limbus, right? So this will be constricted with the your at the limbus, the location of the limbus, but the tear will be seen in the your peripheral, right? Periphery, you can see there will be the seen is this. Now, scleral changes. Of course, the scleral changes will be also seen in this. What kind of scleral changes? The sclera will be getting thin and the blue. I hope you remember from your pediatrics knowledge that the blue sclera is also seen in the osteogenesis imperfecta, right? This is the blue sclera. There is also presenting of the blue sclera in the your congenital glaucoma also, can be seen in the congenital glaucoma also. Now, the other sign, there is a deep anterior chamber will be going to seen over there due to this your your enlargement of the cornea, and iris changes will be going to seen, and the lens flattening. Why the lens flattening? Because this aqueous humor will be going to push the lens, right? This is the lens, and this aqueous humor will be from the your anterior side. It will be going to pushing this lens, right? Because it's the accumulating over there, so it will be going to push the lens the backwards, right? And that is known as your lens will be getting flattened, right? So this is known as a lens flattening. Also, there is a Barkan membrane. What is this? Barkan membrane may be presented. This Barkan membrane is situated on your trabecular meshwork. And what is this trabecular meshwork, guys? Please understand this part. Now, at the angle of anterior chamber, we have a mesh-like work structure. What we have, like this is the angle of anterior chamber. Just I'm talking about it. This is the cornea, and this is our iris. So this is the angle of anterior chamber right here. So here what we have? Here we have a trabecular meshwork. This meshwork is over here, right? This is known as the trabecular meshwork, and this trabecular meshwork is having what the having the function of the filtration of this your aqueous humor, and then it will be going to drop into the your Sims canal, right? Now, if there is a membrane is covering over here, right? If the membrane is covering over here, this meshwork, so this will be not going to allow the passing of your aqueous humor. So this is known as your Barkan membrane, right? This is known as your Barkan membrane. Okay, so this is the Barkan membrane. Maybe there is a Barkan membrane may be presented over here, and because of this Barkan membrane, it blocks the angle and obstruct the flow back, and that's why the flow which is getting out, this is getting out, which the aqueous is getting out, this will be getting obstructed. This flow will be getting obstruction, right? What about the examinations, guys? Please remember about it. The examination, again here also we have to do the comprehensive examination assessment for this, and this all should be done under general anesthesia, because the child who is having the congenital or maybe the developmental less than 3 years of the age the child is there, the child is not allowed to you to do this all the examinations, right? So that's why we have to do this all the initials in the under the general anesthesia only. Just talking about this treatment part, please remember in the treatment part there is a surgical treatment is only possible, right? In the medical management we can give the anti-glaucomatic drugs, but it will not be going to work because there is a totally the membrane is available over there. So that's why we have to do the trabeculoplasty, or we can do the trabeculotomy. Okay, we can remove this trabecular meshwork, or we can do the trabeculoplasty of this. All right, we can repair this trabecular meshwork so that we can so that this aqueous can be flow out, right? So this surgery is only the possibility. Treatments are here for this your congenital glaucoma. All right. Okay, now moving forward for the primary open angle glaucoma. The name is saying primary open angle. It means the angle should be remain open. Okay, so the angle, which is which angle we are talking about, the again open angle is which angle? Open angle of anterior chamber. Okay, we are talking about the which angle? We are talking about the angle of anterior chamber, right? The anterior chamber angle should be remain open. Okay, not only this, the types. This is the primary glaucoma with the no clear systemic or the ocular causes. There is a no more causes are here for the ocular causes if I am talking about it. So there is a no other ocular causes is not there, right? It means there is a no other disease related to the eye disease is not there, right? No other eye diseases they are presented, right? This is the primary, right? If I'm talking about the secondary, if just I add the word secondary, it means it is due to the any other diseases. This is the secondary disease, right? So We are not talking about the secondary, we are talking about the primary disease. We are talking about the primary glaucoma, right? No other. What is the onset of this? Please remember about it. This is having the adult onset and the chronic onset, chronic and slow growing progression. Okay, this is having very slow progression, and the typically this is the asymptomatic. If I'm talking about this the typically it is your asymptomatic until in the advanced stages. So as it is a chronic, now listen this part. Adult onset of this disease. Also, if I'm talking about it, this the patient is having the asymptomatic. What do you mean means guys the asymptomatic? The patient is having the no symptom. If the patient is having no symptom, now listen this part, why the patient will come to the doctor and visit to the doctor that just do the my checkup. If the patient is not having any symptom, and in the Indian population, it is never ever possible, right? The Indian population is not go to the for the regular checkups and right, and just they will visit the doctor when they have the issues only, right? So there is a no possibility that this patient can come into the early stages. This is very rare. Now, if I'm talking about the intraocular pressure of this patient, the intraocular pressure of this patient is very slow progressive rising in the intraocular pressure, but surely there is also the increasing more than 21 mm Hg. Of course, as we talked about it, ocular hypertension should be presented over there. Otherwise, that will be going to cause at what known as that will be going to known as your low tension, right? So we are not talking about the low tension, just we are talking about your there should be the increasing of the pressure. Now, optic disc changes. What kind of optic disc changes there? There is a characteristics optic disc cupping and specifically visual field defects will be going to seen over there, right? So there is a cupping will be also seen and the visual field defect will be also seen over there. Also, there is a what kind of disc, there is a what kind of optic disc changes will be going to seen. Just check it out, right? Just check it out. The first of all, this you can see over there, this is the optic disc, or we can say the optic cup. This is the optic disc. Okay, this is the optic cup and the optic disc. So what kind of the same will be seen? The first of all, there is the enlarging of the cup, example 0.6 or more. The normal size is the 0.3. Just remember the normal size is the 0.1. This is the cup disc ratio. Okay, cup disc ratio. Okay, this is the cup disc ratio. Now, as this is the normal, so if it is increasing 0.6 or more than it, right? If I'm talking about more than 0.6, if I'm talking about the more than 0.6, right? If it is more than 0.6 than 1, right? So this will be the more, right? Of course, and it may occur due to the constrict expulsion, right? And now this disc will be, this cup will be enlargement will be there. The first of all the thing. The second thing, what will be the same? This is between this cup and disc. This area is known as neural rim, neural retinal rim. Okay. Now, as this cup will be going to enlarge, so there will be the decreasing, there will be the decreasing in the neuroretinal retinal rim. There's a neuroretinal rim will be going to decrease, right? Now, the third thing, as you can see here, all the blood vessels are passing through the disc easily, and due to this glaucoma, there is a nasal shifting. There is a nasal shifting of there is a nasal shifting of blood vessels. Okay, there is a nasal shifting of the blood vessels. So you can see over there what will be going to happen. This all the blood vessels will be going to shifted over this side of the disc, and this is the all the three things should be presented in the patient of in the patient of your glaucoma, right? Primary angle glaucoma. I think it was not visible to you guys. Just now you can see over there. Just I'm revising. There is a cup disc ratio will be going to increase. There will be the decreasing in the neuroretinal rim, and the third will be the your nasal shifting of this vessels. And now you can see over here also there is a sphincter hemorrhages may be presented or near the optic disc margin. Some as a hemorrhages, some particular hemorrhages will be going to see the pallor of the disc area on the disc areas, right? And the atrophy of the retinal nerve fiber layer may be seen with the red free light, right? So there is a the layers of the retina which we have to talk about in the later part. So they will be going to the layer will be going to affected atrophied, right? What is the pathogenesis? The age. First of all, as we talked about, is seen in the older ages, or we can say the adult onset. So this will be the more common in the 5th to 7th decade of the patient. What are the races are having this? The more commonly severe in the black populations. Also, the risk factor is available. High risk patient have the myopia patient. So the high myopic patients are having more risk over there. Also, there is a diabetes is having the higher prevalence in the glaucoma, open angle glaucoma. Smoking is there, increasing. Possibly they will increase the risk factor. Hypertension, guys. Please remember the hypertension. It is a higher prevalence in the hypertensive patients. There's the higher prevalence is there. Also, thyrotoxicosis, this is the higher prevalence is seen in the Graves disease patients, right? As the hyperthyroidism is there or the thyrotoxicosis. Also, in the your IOP pathogenesis, if I'm talking, increasing your intraocular pressure pathogenesis, if I'm talking, so there is a decrease the aqueous outflow due to the trabecular sclerosis, or we can say the thickening with the age. So this is the trabecular meshwork which we talked about it, like this meshwork structure we talked about it. Now this meshwork structure is having the sclerosis, or we can say the sclerosis means the hardening of it. Why it is getting hardening? Because of by the age of it, okay, or we can say the thickening of it, right, due to the age. So the this now this meshwork is getting thicker, right? If the meshwork is getting thick, right, so due to this thickening of this meshwork, the aqueous cannot get the outflow, right? This outflow is obstruction, right? And please remember the steroid responsiveness. Maybe there is this, the patient is having over the steroids, so the patient can get this trabecular meshwork sclerosis, right? So these are the your pathogenesis. Also, from the topic we are talking about it, that the patient is having the field defects. Field defects. So what kind of the field defects we are talking about it here? So just remember about it. The patient is starting with the bearing of the your blind spot. So the patient is having, this is the blind spot. Okay, we have the physiological blind spot. So there is an increasing of the enlargement of this blind spot only, the first of all. Also, the secondly, what will be the scene over there? There is the superior paracentral blind spots will be, or the paracentral scotomas will be going to seen. So this value you can see, this is the superiorly, they can start with this. You can see the superiorly, it is increasing with this. Okay, so this is the superior increasing of the your, or we can say the superior paracentral scotoma. After this paracentral scotoma, on the other hand, we can see over there is a nasal step, right? What is the mean of nasal step? You can see over here, this is on the nasal side, we can see the as step like structure. This is known as a nasal step, right? Now with this nasal step, or this is superior paracentral, if they both will be joined together, right, if they both will be going to join together like this is known as your Berger's scotoma, right? This will be going to known as your Bergem scotoma. Also it is known as arcuate scotoma. This is also known as arcuate scotoma. Not only this, we can see over there is a double arcuate scotoma. What is the mean of double arcuate? If this arc is covering on the superior side also, like this, and if this arc is covering the inferior side also, like this. Okay, this is known as your double arcuate, right? This is known as your double arcuate scotoma, double arcuate scotoma, also known as your Ronin's central nasal step, right? Also known as a Ronin nasal step, also known as the tunnel vision. Okay, this double is known as tunnel vision. Okay, so the patient is having the tunnel vision, like if we are passing through a tunnel, right? If I am passing through another tunnel, so what we can see, guys, we can see the last, the small part of this visibility is there, light, and all the surround is what is it, the all the surround is the totally darker. So that is known as your tunnel vision. And the last one, which is the here, there is a total scotoma. Right? So there is a patient is having the totally blindness. So these are the your visual field defects which will be going to seen in this. Okay. Now, what will be the symptoms will be there, right? Please remember about it. What will be the more symptoms are there as we talked about it, because it is asymptomatic, right? But there is the frequently changes in the press biopic glasses, because in the fifth, seventh decade, we are talking about the fifth or seventh decade of the life the patient is having this. Okay, so the symptom, the all the other things are the asymptomatic. We talked about it, right? The patient is remain in the asymptomatic, right? But if there is a symptom will be present only and only what the patient is having the frequent changes in the press biopic glasses. Now, what is the diagnostic tool for this? If I'm talking about the glaucoma diagnostic tool and the criteria, so there is a first of all we have to do the tonometry. And guys, what is the use of this tonometry? In the use of tonometry, you know very well, it measures the intraocular pressure. What it is going to do? This tonometry will be going to measure the intraocular pressure. Also, we have to see the dineural variation test. And what is this dineural variation test? It defects the early glaucoma cases. Okay, it defects the early glaucoma cases by monitoring the intraocular pressure fluctuations. What do you mean by this? That if I do a patient's morning and evening, two times I do this patient's glaucoma test, okay, the tonometry. In the morning, I'm getting the 10 mmHg. This is the lesson. If it is more than 8, it is the glaucoma. So it is a feature of glaucoma. Please remember about it. It is a feature of the glaucoma. Also, we have to do the gonioscopy test. What we have to do? We have to do the gonioscopic test. And why we have to do this gonioscopy? Through this gonioscopy test, we're going to see there is a wide open of angle or not. If angle is open, then only we can say this is the open angle glaucoma. If the angle is closed, we're going to say this is the other type of glaucoma, which is the angle closer glaucoma. Angle closer glaucoma. Next, optic disc documentation. Again the same. We talked about is all the changes, which is all the glaucomatous changes, which I told you. There's the disc changes are like your, first of all, as we talked about it, the disc changes will be going to seen over there, like we talked about it already. The nasal stap, the visual field effects will be also available, but in the optic disc there will be the increasing in the cup ratio, right? Cup disc ratio, as we talked about it. Not only this cup disc ratio will be going to increase over there, there is also neural thinning of the neural retinal rim, and please remember neural retinal rim, and the last one which should be also presented over there, that is the nasal shifting of the blood vessel. So this all the three, please remember this, all the three disc changes should be presented over there. Now, not only this, the diagnostic test just should be done. We have to examine this on the slit lag exam. We have examination. We have to see exclude the all other causes of the secondary to the glaucoma. Right? Is there no any other pathology is present which is causing the glaucoma? Right? So we have to rule out. We have to rule out this particularly. Not Not only this, we have to do the parametry for the visual field defects, right? What kind of the visual field defects is there, and we have to use this criteria like a mean, median, or coma hemifield test will be should be done. Also, we have to do the nerve fiber analysis. We have to do the nerve fiber analyzers, and by this, what we can do, we can detect the early retinal fiber damage. Right, we can early do the detection of the retinal nerve fiber damages. Also, we have to do the provocate test. We can do this all the tests. By the water drinking test is what? By the drinking the water glass, there is an increasing in the more than 8 mmHg in the intraocular pressure, right? If I measure now and as after drinking the water, like after the drinking the water glass, there is an increasing in the intraocular pressure more than 8 mmHg. That is known as the provocative test, right? It means we are provoking it, okay? And this is a suggestive of your open angle glaucoma, right? And please remember, these tools are for the early detection. Why we are talking about so much tools? Because they will be going to make your early detection, because this open angle glaucoma is asymptomatic. As I told you in the starting only, there is a no symptom will be in the starting, there will be the present, right, before the stabilizing it. So if no symptoms, then what we have to do, we have to do this test, and by the doing this test only we can get the that patient is having this glaucoma. Now, what is the glaucoma diagnosis criteria? For the diagnosing it, the primary open angle glaucoma, the IOP should be more than 21 mmHg. The first thing, the glaucomatous optic disc cupping and visual field changes. All the three, as we talked about it, optic disc and the visual field changes will be three. Also, diagnosed with the raised intraocular pressure, either the typically field defects and the changes. And please remember, ocular hypertension is the glaucomatic suspicion. Only it is giving the suspicion, okay? But if it is more than 20 mmHg without the optic disc and visual changes, that is, we can say the ocular hypertension. Only the ocular hypertension, right? If only the increasing of intraocular pressure, no other symptoms are not present, we don't say this glaucoma. Just we say the ocular hypertension. But what is the normal tension glaucoma? As we talked about it, if there is a glaucomatic disc cupping without the visual field changes and the intraocular pressure is less than 21 mmHg, that is known as a normal tension. Okay, normal tension glaucoma. Okay, now management of it. Just talking about the management of it. Please remember, it includes the visual acuity test, slit lamp test, tonometry, optic disc evaluation, gonioscopy, and the visual field charting. The first of all we have to do. Also, we have the severity grading, which is the AAO grading. And what is the AAO grading says? The mild is one, which is the optic nerve abnormalities with the normal visual field. But what is the moderate is saying? Moderate is when the visual field abnormalities in one hemifield not within the 5 degree of fixation. But if the severe is there, there is a visual field abnormality in the both hemifield, the both half of the fields within a 5 degree of the fixation. Please remember, that is known as your severe, severe grading of your glaucoma. What kind of therapy should be given in this? Please remember about it. We can use the medical therapy. And the medical therapy, we can give the mannitol IV, which is the 1 gram per kg body weight to lower the IOP, where is the increasing the intraocular pressure. So first of all, we have to low down the your intraocular pressure, or we can say we have to decrease the intraocular pressure. First of all, the second one, what I have to do, the secondly I have to do in the secondly I have to do in the patients, that I have to do the acetazolamide, the tablet, or I can give the IV injection 500 mg, or just the 250 mg orally 3 times a day. I can give this patient. Okay. Now, just a minute, guys. Is there more lag seen to this? You are messaging there is a lag of it. Is there any lag, is guys there? Is there any lag, guys? Just let me know, guys. Is there any lag? Maybe due to the bad weather, there is a lag issues there. Yes, 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 doctor. I read your comment that this is lagging over there. Doctor, just check your internet. I think from my end it is going good. I'm checking my net speed. It is going good from here. Just let me know what about the others. Others are also feeling the same or having the same issue. Let me know in the chat box, guys. Let me know in the chat box, guys. Is there any lag? Just let me know in the chat box, guys. Is there any lag? I'm trying to see the net speed and everything. It's going good from my end, but I don't know from. I'm waiting for a response in the chat box, guys. Sorry for the disturbance. I don't know why this lag is there. I can see, guys, your chat. Just let me know in the chat box. I think now it's perfect, right? Now it's perfect. Yes. Now there is a no dropping of frames is more over there. Even I'm not cannot see the chat over also. Some issue from the YouTube. Even I cannot read the chat. I think you guys are replying or not replying. I don't know, but it's not showing the chat also. Just wait for it. Sorry for this technical disturbance. I'm not expecting this, but I don't know why it's here. Yeah, I think I think just now it seems good as I change the internet connectivity. Now it's going good. Let's continue, right? Let's continue. Okay, let's start. So we are talking about the medical therapy of this. The first of all, the mannitol is given 1 gram per kg body weight for the lowering the intraocular pressure, and the acetazolamide should be given the 500 mg IV or the 250 mg orally 3 times a day. Also, we have to give the some supportive care like analgesics and antiemetics is needed if needed. Okay, as it is needed, maybe the patient is not having the nausea or vomiting, so we don't give the antiemetics. But if the patient is having this, so we have to give this. We have to give this. Now, moving forward for the next one, we have to give the pilocarpine. We have to give the pilocarpine eye drop and start with the 2% of drop after the IOP reduction, and it will be the effective if there is a iris sphincter in ischemia, right? And also we can give the beta blockers like timolol or latanoprost, or we can give the prostaglandins also. We can give the beta blockers like timolol, and we can give the prostaglandins also like latanoprost, right? The combined that if one is not sufficient, so that is known as the combination or we can say the combined therapy, right? If I'm combining the two drugs, right, for the using the treatment of it, so that is known as your combination therapy, or we can say the combined therapy, right? We can say the combined therapy. Now, not only this, if I'm talking about the adjacent therapy, this is the your dorzolamide pilocarpine as the additional treatment. If you are using the dorzolamide and the pilocarpine, that will be known as the adjunctive. And the next, the laser tuberculo, your trabeculoplasty, right? So we are correcting the trabecular mesh, which is sclerotic, right? Which is the already sclerosis is there, right? If I'm treating that, if I'm correcting that through this lasers, right, doing the surgery, when the IOP is not controlled by the medication, so we have to do the surgery. So the surgery is for the, your advanced cases, which is the non-compliance and the failure to the other treatment or the failure of the medical treatment. Okay, if the failure of medical treatment is seen there, so now we have to do what? Now we have to give the now we have to do the surgical treatment. What is the next? Next we have the peripheral iridotomy. What is this peripheral iridotomy? This is the your we can say the bypass pathway we are creating over there to the bypassing the iris for the like from the, it is passing from the pupil, right? The your aqueous humor is coming from the posterior chamber to the anterior chamber through the pupil. So we are bypassing it for the it in the for the uncontrolled for the 50% of the peripheral anterior synecdoche or the prophylactically in the fallow eye. If the patient is having the glaucoma in the one eye, so we can do the prophylactically for the second fallow eye, that the patient is not going to get the in the second eye, right? For the patient is not getting the in the second eye. Now, not only this, we can do the laser iridotomy and for the non-invasive alternative also. Also, we can do the filtration surgery. What is the mean of filtration surgery? For the uncontrolled IOP for more than 50% of the peripheral anterior synecdoche, we allow the aqueous drainage into the subconjunctival space. So we made the what? We made a different pathway, or we can say the area where this aqueous can be drained out. Okay, so the aqueous can be drained out over there. Right now, next, the clear lens extraction. Also, we can do the in the phacoemulsification with the intraocular lens implantation. This is a clear extraction. Prophylactically, we can do the laser iridotomy, as I already told you, as a surgical iridotomy, and the asymptomatic fallow eye, which is the second eye. We have to do that. Monitoring, we have to do the regular follow-up for the disc, for the visual field, and the IOP assessment also, as per the targeted pressure is needed, right? So we have to adjust the target and we have to pressure for the target pressure, and as we need it, so we can decrease and increase this, or we can measure it. The surgical indications, guys, please remember, we're not going to do surgery like that. We have to should be there is an uncontrolled glaucoma despite of the medical therapy using if the medical treatment is failed, or in the advanced disease with the high intraocular pressure and the significant visual field losses seen over there. So this is all about the your open angle glaucoma, guys. This is all about the your open angle glaucoma, and now we are moving forward for the next one, which is the your angle closer glaucoma. Right now we are moving forward for the next one, which is the your angle closer glaucoma. Okay, now moving forward for the next one, which is your angle closer glaucoma, guys. Just by the name only you can understand the angle is closed, which angle of anterior chamber is closed, right? The clearly mentioned over there. And now, what is the etiology or predisposing factor over there? First of all, the anatomical factors. First of all, we are talking about the anatomical factors. What are the anatomical factors? The patient are hypermetropic eyes or with the shallow anterior chambers. The patient is having the with the shallow anterior chambers and the anteriorly placed iris lens diaphragm, right? This is the important, or we can say this the ACIOL also, anterior chamber intraocular lens implantation. That is also can be cause over it. Also, the narrowing the anterior chamber angle, like the small eyeball, larger lens, a smaller cornea, or the larger ciliary body. These can do this. All the factor can do what? This all the factor can do the all the factor can do the what? The narrowing of the anterior chamber. The narrowing of the anterior chamber. Now, if there's a narrowing of the anterior chamber is there, okay, so what can be happen? It easily, if the narrowing of the anterior chamber is there, this iris can easily attach with the your lens and make the synecdoche over there. Okay, so that's why this is the very important feature. Now, in the journal, if I'm talking about it, age the more common in the fifth decade of the life. And if I'm talking about this, especially about the sex, there is a female predisposition is there. So if I'm talking about the male female ratio, so one male, there is a four female will be seen by this your angle closer glaucoma, right? Angle closer glaucoma. Not only this, if I'm talking about it, so it will be the more in the females, right? We talked about the clearly it is a more in the females. Now, moving forward with the other general symptom, there is a personality. The person who is more common in the nervous individuals. There is a personality. The person, if the person is having the more nervousness, it is more common over there. And the season is there. This is the peak incidence in the rainy seasons. Please remember about it. It is more commonly seen in the your rainy season. Seen in the rainy season. Also, guys, still is it lag is there? I don't think so, guys. Okay, I don't think so, doctor. Just check your internet. Okay. Also, there is a family history and the race is participating over there. Also, we talked about the hub stria, right, which is the horizontal stria. Horizontal, right? Horizontal stretch marks is there, right? Now, we are talking about the next. There is a triad will be going to see. And what is the name of this triad? This, please remember, this Vogart stria is different and Vogart triad is different, because the question is asking you the Vogart's. The question is asking you what? The question is asking you the Vogart's triad is used for, and you are thinking this is Vogart's stria, okay, and you mark the keratoconus. Not, guys, the Vogart's triad. If they are asking triad, okay, then it will be your what? The triad will be come into your the three things. Triad will be the three things. The three, all just three triad will be coming into the your uh, coming into the your angle closer glaucoma. And if I'm talking about Vogt stria, so Vogt stria will be going to seen into the your keratoconus. Keratoconus. Done. Now, moving forward, the next with the what will be the triad? The three things. The first one will be the glaucomoflecans. It means the anterior subcapsular lenticular opacities. The second one, the patches of iris atrophy, and the third one is the slightly dilated, or we can say the non-reacting pupil due to the sphincter atrophy. Due to the sphincter atrophy, what will be going to see in there? Non-reacting pupil. Also, we can say non-reacting pupil or slightly dilated. It means you can write the mid-dilated pupil. Okay, we can say this to the mid-dilated pupil, right? Or mildly dilated, right? It is a mildly dilated. It means not the fully dilated, not the fully constricted. It is a mid-dilated. Okay, it is remain the mid-dilated. Now, what are the precipitating factors? What are the precipitating factors? The first one is the dim emulsions. What is the dim emulsions? Like the movie theaters. Okay, what is the dim emulsions? Movie theaters. The second is the emotional stress, and the third one is the mediatric drug. If the patient is having atropine or maybe phenylephrine, this can be caused as the your participating factor, right? Also, not only this, these are the factors which is can be caused But what kind of the clinical presentation will be there? In the clinical presentation, there is a latent primary angle closure glaucoma, or maybe subacute primary angle closure glaucoma, or maybe the patient is coming with the acute, there will be the acute primary angle closure glaucoma. Now, by the word of acute, please understand this, by the mentioning this word acute, acute it means the sudden onset, right? So the please remember about it, it will be the sudden, and the patient is coming with the severe pain. The patient is coming with a severe pain in the eye. The vision loss will be there, nausea, vomiting, and the markedly IOP raised. It means it is 40 to 70 mmHg. Guys, the normally it is, I already told you the normal value of intraocular pressure. I hope you remember about it. All right. I hope you remember about it. What is this? Right. This is your 10 to 21 mmHg. Just I'm writing again here. 10 to 21 mmHg is the normal values, right? This is the normal value. But if it is increasing, markedly increasing into the acute primary angle closure glaucoma near the 40 to 70, what kind of the signs will be going to seen over there? Please remember, in the sign there is a red eye will be there, and the corneal edema will be going to seen. The anterior chamber will be getting shallow. Please remember, in the open angle it was the deep. Here it will be the shallow. And please remember there is a fixed mid-dilated pupil will be going to see. Okay. So there is a fixed, it means it is non-reactive to the light. Okay. It is non-reactive to the light. It is not going to react the light. Now, the treatment. What we can do the treatment? Guys, please remember it is a medical emergency management should be given. And what is the emergency medicine? Please remember, we have to give the mannitol for the decreasing the IOP. We should give the acetazolamide uh, for the increasing the flow by uvoscleral pathway. We can give the pilocarpine, and it will do the breakage of synapse. And we can give the beta blockers for decreasing the intraocular pressure and increasing the flow. Also the corticosteroid can be given, and we have to should followed by the surgery. What is the surgery? We have to do the laser iridotomy or the filtration surgery should be done. Okay, so this is about your acute primary angle closure glaucoma. But if I'm talking about the chronic, there is a gradual synecdoche which is closer leading the chronic high intraocular pressure. Of course, the optic disc cupping, visual field loss, and this is should be confirmed or done by the gonioscopy that angle is closed. If angle is open, it means it is an open angle glaucoma, right? So we have to confirm it by the your gonioscopy that this is totally your angle is totally closed, right? Now, what is the treatment for this chronic one? Please remember, in the chronic, we have to do the laser iridotomy or the trabeculotomy. Okay. For the absolute posterior angle closure glaucoma, we can do the Fridgman's test for the absolute one. For the differentiating between the color halos in the glaucoma and the conjunctivitis and the cataracts in by the Fridgman test, we can differentiating between this, right? The color halos which are coming from here, it is due to the glaucoma, conjunctivitis, or the cataract, or by the cataract, right? So here we finish with the two important diseases, which is the cataract and the glaucoma, because they always and always coming into your exams. Now, just wait for a minute, and what we are going to start, just a minute, we are going to start with some MCQs. Just a minute for it. Just wait for a minute. Some MCQs which is more commonly come into your uh, commonly coming in your exam, or we can say the some previous year questions are also there. So we have to talk about like neuro ophthalmology and some more questions are there. So let's talk about these questions. Just a minute. Yeah, is it clearly visible to you guys? Perfect. Done. Let's start with this question, and we are starting with this question. The first question is in front of your screen. Okay, I hope you can see this question, guys. Just let me know about this answer of this question. I think you can see this question on your screen. Yes, this is your previous year question, so that's why I'm talking about these questions. Some previously they are highly they asked the question, so that's why I started with this. Okay, very good, doctor. Very good, doctor. You are answering C. Why, doctor, you are starting with the keratoplasty directly? Can you reply me in the chat box, guys? Why you guys are answering C? Some are replying C, some are replying A, steroid and antibiotics. Guys, listen this part. The question is clearly mentioning a patient come with the pain, redness, and left eye with the injury during the welding. It means there is a foreign body. The first of all, you have to identify that what we are having here. We are having here the your injury with the welding. It means the welding the patient is having. It means the patient is having the foreign body. Yes. What is the patient is having? The patient is having the foreign body. It is a sure, right? And as this patient is having the foreign body, as during this welding, the patient is having the foreign body. The patient is having what? The patient is having the foreign body is there, right? If the foreign body is there, now listen this part carefully, guys. If the foreign body is there, the what is our management is saying? The management is saying here, first of all, we have to remove it. Okay, the management of it is what? The management of it is the for the removal of it. Okay, so the answer is what here, guys? Please remember the answer is here the removal by the 26 gauge needle. First of all, I have to remove this. I have to remove this foreign body, and after the removing this foreign body, now I have to give the antibiotics and steroids. So please remember, they are asking you just what is your next step. Okay, they are not asking you which is the best. Okay, they are not asking you which is the best. Okay, so don't be confused, don't be confused in this, right? And please mark always the answer by thinking of it, that what is they are asking. Okay, so always they are giving you the some different and they are giving you the confusing answers. Okay, now answer this. Now please answer this. This is a very important MCQ, and that's why I'm covering over here also. I'm waiting for your answers, guys, in the chat box. I'm waiting for your answers, guys. Who guys are watching live, please try to reply. Please try to reply in the chat box. I'm waiting for your answers. Very important MCQ from the retina topic. Just reply me in the chat box. Very important topic. Very important question. The by seeing the image, you can understand this. That ophthalmoscopic image is given, shown the below, is the likely diagnosis. By the seeing this image, you should keep the this image as a, like we can say, remember, just by seeing the image you can make the diagnosis, just the seeing the image. Okay, and this is the known as a very known name of this particular your particular of this particular sign, we can say, right? Please try to reply me in the chat box. I'm waiting for your answers, guys. Don't be confused, don't be confused, just try to reply, just try. Very good, guys, very good. So this is what This is the your answer is your central retinal artery occlusion. It is your arterial occlusion. Why guys there is a arterial occlusion? Just listen this part. The periphery you can see this is the pale. Okay, and your fovea is seen the red, and that's why this is known as cherry red spot. Yes, this is known as your cherry red spot. And guys, please remember about it. This cherry red spot is seen in the cherry red spot is seen in the your central retinal arterial occlusion. Okay, so in the arterial occlusion, we're going to see what? In the arterial occlusion, we're going to see your cherry red spot. Okay, we are going to see the cherry red spot. Understood? Very good. Now, moving forward for the next MCQ. Moving forward for the next MCQ, that is your again. I'm talking about the uh, your question, which is the more likely to come in your exam. I'm going to ask you that question. Just see this image and reply me in the chat box. Just see this image and reply me in the chat box, guys. Just by the seeing this image, reply me in the chat box. What is this patient diagnosis? They're asking you clearly the diagnosis. Clearly, the question is asking you the diagnosis, nothing else. Very good, doctors. Try to reply, guys. Try to reply. Okay. Very good, doctors. Try to reply, guys. I'm waiting for your answers. I'm waiting for your answers, guys. Very important image for the exam purpose. Very important. By the seeing the image, you should understand the answer, right? That's why I'm asking this. Try to reply, guys, in the chat box. Okay. Now, listen this part. What is this? What is this? You can see the totally retina is now red here. Okay. And this is the some exudate is also there, right? We can see the hard exudates, yellow color. This is the your tomato splashed appearance. Okay. What is this? This is the your tomato splashed appearance. By the name only you can understand. It means it seems that someone is splashed the tomato over the retina. Okay, someone splashed the tomato over the retina. Okay, so this is known as your tomato splashed appearance. We talked about the central retinal artery occlusion just now, which is the cherry red spot. Okay, this is the cherry red spot. Just we talked about it, right? But what is the tomato splashed appearance? Where it will be going to seen? Yes, it will be going to seen in your central retinal venous occlusion. Okay, so where it will be going to seen? It will be going to seen in your central retinal venous occlusion. Clear, guys? Now, moving forward. Moving forward, there's again someone is messaging that there is a lag. Can you reply me in the chat box? Is there any lag? Is there? Why you guys again saying there is a lag? Because from my end it is totally going good. No dropping of frames or any other things. Just I'm checking the speed or the streaming quality. Just I'm accessing that only. I cannot see the any issues from my end? Okay, I don't know why this is a lag from, you are saying guys, lag and lag again. Maybe it's the internet issues is there from my end or your end. Is I'm clearly audible and visible to you guys? I think there is a network issue due to the bad weather, I think. Just I'm starting the live on my different side. I think there is a network issue, guys. We cannot continue this session for more longer. There's a network issue. I think there is a too much lag is I can see on the my screen. Just I'm dropping this my Telegram personal handle and Instagram handle. So if you guys have any query related to this sessions, or maybe any related to the ophthalmology as we conducted the sessions, right? So you guys can contact me over there, right? And we plan shortly. I will surely plan a quick like a Q&A session for the ophthalmology shortly, okay? Just before the 4 or 5 days or 3 days, 4 days before the exam, so that you can easily recall just before the exam, okay? So I will try, okay? I will try to do this, okay? I think there is a network issue from both end, like from my end I can see also, right? There is a issue, okay? Sorry for this technical issues was there because of due to bad weather, I think. So that's it for today, guys.